We'd like to thank our sponsors, Maxwell Tech, Steno Health, and Levo.
Hello, I'm Jennifer Maxwell, co-founder and CEO of Maxwell Tech. Here at Maxwell Tech, we believe that no family should ever feel forgotten after that last visit. Too often, grief leaves families feeling isolated. That's why we here at Maxwell Tech created Nana Connect Bereave, a simple yet powerful way for care organizations to extend compassion beyond the bedside. Bereave really does deliver timely, personalized messages that bring comfort and connection when families need it most. Our largest hospice partners are sending out over 10,000 messages a month. That means that over 19,000 family members are being connected to their care teams in meaningful ways. And the results are extraordinary. Engagement scores are running between 30 and 40%. Families love being supported in this manner, and the results are seen in their engagement. Bereave is already touching millions of lives today, and we are just getting started. If your organization is ready to bring humanity and healing into bereavement care at this scale, please visit us at maxwelltech.com.
This episode is sponsored by Steno Health. Steno is the only enterprise-level documentation platform built specifically for home health and hospice. While many tools rely on quick fixes that don't scale, Steno is designed to integrate directly into the systems agency already use, so documentation is accurate, compliant, and ready for billing at scale. Developed by clinicians for clinicians, Steno uses ethical and compliant AI to reduce paperwork, strengthen quality, and give teams more time with their patients. To get more information on Steno, go to stenohealth.com. We'd also like to thank our episode sponsor, Levo, a company that's changing the way home health and hospice organizations approach staffing. Levo's platform streamlines recruitment by working around the clock in the background, helping agencies connect with the right candidates faster. It also uses data-driven insights to identify potential employee challenges before they turn into preventable turnover. And the impact is clear. Organizations using Levo have seen time to fill drop as much as 40% and retention improve by 20%, all within that first 6 months. To learn more, visit hellolevo.com and be sure to tell them that I sent you. First of all, let me welcome to the podcast, the second episode of Last Visit First, April Anthony. April is the CEO of Vital Caring. She's also the chairman of the board of Homecare Homebase. She's the chair and the board of trustees at Abilene Christian University. She was the founder of Encompass Home Health and the founder of Homecare Homebase. She's an amazing mom, an amazing spouse, and we'll get into a little bit of that too. She's been my mentor for many years and a very good friend of ours. So we're happy to welcome April Anthony.
Hello, good to see you, Tom. And that was a glowing list of things. I've actually shifted away from my role as executive chair of Homecare Homebase, but I'm still actively consulting with them, and I'm excited to be working with them and their new leadership, and enjoying getting re-engaged in a company that I've loved from the start.
Yeah, it was an amazing feat, April, and the whole industry knows who you are and what you are, and they're all excited to hear what you have to say today. So let's start out. I think back to how I met you. It was in July of 2005. You had a old boss of yours and mentor of yours named Steve Myers, who was my CFO at a company called Millbrook, and I know he was applying for a job at Advanced Home Care Management back then, before it was Encompass. And Steve gave you my name, and I actually came over and interviewed with you and Guy and Celeste, and got the job. That's where we first met. That was in 2005. I don't know if you remember that, but I really appreciate Steve throwing my name out there.
I remember having lunch at a place in Addison. Yeah.
That's right. Exactly. And then the first week I started on the job, we went to knock, and my job was to hand out water and Cracker Jacks at knock. I don't know if you remember that too.
I do remember that as well. For the baseball uniform.
Yeah. I didn't know a single thing about home care or Homecare Homebase, but I was good at handing out Cracker Jacks. So, well, cool. Let's talk about your story, April. Everybody wants to hear your story, and I've seen it online a few times. You've told some amazing stories about yourself, but how did you get into this business?
Yeah, it was, I guess you have to say it was a God thing. I was at Pricewaterhouse, working in the audit division there for about 3 years. I had gotten married and moved to Dallas, and I kind of fell out of my sweet spot. I'd been working in oil and gas and banking, and kind of had a pretty narrow focus when I was in Houston. I came up to Dallas. I kind of got thrown into the general pool, and I just wasn't loving it. As a matter of fact, I was pretty confident that I wasn't going to love, public accounting no matter what I was doing. I really thought what I was going to love was being a stay-at-home mom. So I thought, if that's really the grand plan, then, why kill yourself at Pricewaterhouse? Just go find a job we needed to save money for a couple of years so that we could move on to starting a family. And kind of, I thought that was for certain the path that God was leading me. And so when I went out looking for a job, lo and behold, I ended up getting a job offer for a company in home healthcare, and I had literally done nothing in healthcare in my entire time at Price Waterhouse. I hadn't been close to a healthcare client any time in that period, and so the guy who offered me the job knew my brother really well, and he was like, "Well, he's really smart, so I think he'll probably be okay too." And so he offered me this job. I jumped into it, not because I was so driven or motivated by healthcare, but just because of the job offers that I had. This one was to be in charge, and what I do know about myself is I really prefer to be in charge. And so I thought, well, I'll be in charge of the accounting department. That'll be better than not being in charge of the accounting department. And so I took that job and showed up at a home healthcare company on April 2nd of 1992. And as luck would have it, this company owned 4 different provider numbers, 4 different subsidiaries. And it was way back in the cost reimbursed days. And as I started to put together the first round of financials for that calendar year and see what had happened in the first quarter, what I discovered was that one of the 4 provider numbers was way over the cost limits. And back in those days, if you were over the cost limits, you could lose money, but you couldn't make money. And so that was a pretty bad place to be. So I went to the owner and I said, "Hey, listen, I know I'm new, but you have a problem, I think. You get this one provider number that's going to lose money. Not only is it losing money today, but I think it's actually going to lose more by the time we get to the end of the year than it is currently. So how do you want to pursue that?" And he said, "Well, let's sell it." And I thought, well, who possibly wants to buy a money losing cost reimbursed business? That seemed like a bad combination. So I go out and I start talking to some of my old buddies at Price Waterhouse, like who might buy a company like this? And they were nice enough to make some introductions, and then those introductions would lead to other introductions. But eventually, all of those conversations kind of ended the same, with someone saying, "Hey, thanks, but no thanks. We don't think we're interested in that." So about 2 weeks later, I go back to the CEO to sort of explain, "Here's what I've done and here's who I've talked to." And about halfway through this conversation, the deeply competitive nature within me came out pretty strong, because I'm thinking, "Hey, it's my first actual important assignment, and I'm having to admit that I've failed to find anybody to buy this company." And so, not being one to like to fail, I instead say, "Hey, what if I just buy it?" And he says, "Sold." I'm like, "Well, time out. Buy was the wrong word. I can't buy it. What I really meant is, what if you just give it to me? I mean, it's cost reimbursed. So if you just gave it to me, I'll assume the losses that it has today. You can kind of pretend you never did this. Your other 3 provider numbers will be fine, and you'll end up in the same place that best place you could have hoped for. Me, on the other hand, if I'll take it with the losses that it has, and I don't have the big corporate overhead allocation you have, then I also might get to break even by end of the year. And if I do, I will have bought it for nothing. If I don't, that's how much I will effectively pay for it." And again, he said, "Sold." And again, I said, "Wait, my new husband may have an opinion about this." Know my husband, and so you know that he's fairly easy to convince. And so I went home that night and I said, "Hey, honey, I got this great idea. We're going to buy this home health agency." And he asked the obvious question, "With what?" And I said, "Well, that's the better news. You're just going to give it to us." I explained it. He listened pretty patiently. Finally, raised his hand and said, "Wait, I got one question. What do you know about home health care?" I'm like, "Oh gosh, I don't know anything about home health care," but it just doesn't seem that hard. And with those auspicious words, I returned the next day to begin to complete the process of acquiring a home health agency. And so, at the ripe old age of 25, with 58 days of experience, I became the owner of a money losing, cost reimbursed home health agency. And so that was kind of my trial by fire. Even then, though, not really thinking, much about the long term of it, just thinking maybe I do this sort of I think this will be easy. Maybe I'll just do this part time and still mostly be a stay at home mom. But as I got there, kind of everything changed really quickly. I had to lay off a whole bunch of people the first week that I owned the business, because we couldn't afford to lose money. We didn't have any money, so losing money was not an option. So laid off anybody who didn't have a license, basically, and started doing all the jobs. And one of those jobs was sales and marketing. And so I'm out making sales calls one day, and I think I've got a pretty good elevator pitch. I'm good for about 2 solid minutes, and then after that, I'm pretty much out of knowledge and things to say. And so I'm not making much headway, but I finally get to the back of a physician's office, and I think I'm literally like I can see the referral in hand. She's about to hand the piece of paper across the desk to me when the doctor walks by and says, "Oh, you're in home health care. Like, tell me what you do when a patient has CHF." And for the life of me, I don't know what CHF is. And so I can't answer that question. And he says, "What about COPD?" And I'm like, "No, I don't know that one either." And so I walked out without a referral, but with pretty strong confidence that I couldn't keep doing it the way I was doing it. So the next 2 weeks, really, that moment was transformational. It was transformational because what that did was push me back into like, okay, how am I going to learn this business? And I thought the best way to learn it was to hear stories and to have stories about patients. And so I spent the next 2 weeks riding along with clinicians, nurses, therapists, home health aides, and just trying to learn from them and observe what is home health care, what does it look like, and from the very first day, I was just captured by what home health care can be. Walking into a patient's home and experiencing the challenges, seeing the challenges, whether those challenges were their living environment, their family support or lack thereof, their financial capabilities or lack thereof, their ability to afford their drugs and their medicines and proper food. And you started watching all day long kind of these things that were happening in these homes. And you're just, kind of taken by, hey, this doesn't really feel like a job. This feels like a mission. Like this feels like something you mentioned by Christian faith, and that's always been something that's a huge part of me. But it felt like church work. It felt like the kind of things you go do to take care of your neighbors. And I thought, wow, could I actually have a job that I can get paid to do that is so tightly mission aligned with who I think I am as a person? And that's that really was the thing that captured me was the idea of really transforming the lives of these patients. And then as the afternoons would run along in those days, my brain would sort of be swimming with clinical jargon. I would finally say, "Uncle, I can't I can't take any more clinical info. Just tell me about you. Tell me your story." And what I started to hear day after day were stories that had so much similarity. People who would say things like, "Oh gosh, I knew when I was a teenager that I wanted to be in the caregiving business, so I became a nurse or a therapist or even a certified nurse aide." And sure enough, after I got my credentials, then I went into the hospital. And 12-hour shift after 12-hour shift after 12-hour shift, I just finally felt burned out, wiped out, and I just thought there's no more of me to give. So I left there and I went to a nursing home, and gosh, that was worse. And now I'm here in home health. I'm just kind of hoping this place won't be awful. I remember thinking to myself, okay, well, like, I think I could do not awful. Like, I can figure out how to make a place not awful. Like,
Right.
I can actually figure out how to make it good. What if I could figure out how to make it great? What if I could be the very best place that you could work in healthcare? If I was, I think I'd hire more of these amazing people that I've just spent the last 2 weeks riding along. And if I had more amazing people, I think we'd deliver amazing care. And if we delivered amazing care, I'd have amazing stories to tell about outcomes patients experienced. And that those stories would lead me to have the next opportunity to serve the next patient. And then we would be able to grow. But I think it all starts with like, what if I just become the best place to work? What if I take really good care of these people who seem to really take great care of patients? But no one in the healthcare ecosystem at the time in the early 90s seemed to be talking very much about taking care of them. And I think that philosophy really was the grounding of my whole career in home health care is take great care of your people. They'll take great care of your patients. Great patients will tell people about their experience. Those experiences will lead to your next patient opportunity, and that patient opportunity will lead to your opportunity to lean back in, take even greater care of your employees.
Last visit first came from that. Like, how do we make the last visit just like the first visit, just like the last visit? And, if you're taking care of someone that's dying in their last visit, like, how do we make the first visit that same experience? And then how do we recruit the right talent to make sure that they're doing the right things always for these patients? It's a And by the way, April, you're the greatest deal maker I've ever met. For someone to get a free home health agency in 92, that's the greatest deal maker. I mean, you've made hundreds of deals across the industry, but that was the best story. And I remember you telling me that one, and it makes me smile that like you have no money, no time, no experience, and you became the top home health agency in the United States that everybody wants to follow. So it's pretty amazing. Thank you for sharing that.
Well, it was fun, and it's just been, you just sometimes you don't think about the things in your life that are going to be important. And,
It's true.
I didn't think going out and making sales calls that day was going to be important, but it was literally that failure that became the most important moment in my professional career. It was failing to accomplish that sale that drove me to choose a different approach, that then drove me to go get in the car and actually learn this business at a different level, that then helped me tap into what I now know is my calling in life. And it all happened because of a moment of failure. I think so often people think it's their moments of success that are the jump start to, greatness in their career. But sometimes it's the moments of failure that actually propel you to new heights. And for me, I can think of many times in my career where it was kind of the moment of failure that was actually the catalyst to something great, as opposed to the moment of success.
Yeah. Let's jump forward to Homecare Homebase. What made you want to write your own software for your agency?
Necessity. Necessity actually is the mother of invention, they say. So I had been in home care from 1992. 1998, the interim payment system comes along. By definition, it's interim. And finally, we get to a place where we're about to move into the then PPS system, which was going to finally allow home health agencies to make a profit. And one of the things that really, for my career, was a point of success again, was I started in the hole. And so because our home health agency that we had day one was underwater, it forced me into thinking about efficiencies from the very beginning. So it was like, listen, I can't just operate at break even, go forward. I actually have to operate, at a lower cost going forward, because I got to eat up all these tasks that, overspending that's happened before I got here. So I had to come in and be really efficient right from the beginning. And as an accountant by training, efficiency is kind of my love language. I really like to pursue efficiencies, and so we always kind of operated in a way that was pretty countercultural. Because if you go back to the 90s, what most people did in those days is they thought, okay, if the cap is $100, I want to spend $99.99. Like, I want to get as close to it as possible without going over, because otherwise I'm leaving money on the table. Well, technically, maybe that was right, but whose money are you leaving on the table? The reality is it wasn't profit. You were just going to go distribute it out to vendors or employees or yourself to some degree, but there were limits on that. And so, I always kind of said, listen, what do we need to do to be really great for our partners, being our employees as well as the vendors that we align with? Let's make sure we do the right thing for them. We don't want to just be inefficient for inefficiency's sake. And so we were really countercultural in those cost reimbursement days. We ran about 25% below the cost caps. And that was kind of unheard of in the day. And it ended up being a positive for our organization. It's a tangent we won't tell now, but that structure of running below the cost caps proved to be really beneficial, because when the PPS model came along in 2000, we already knew how to be efficient. We already knew how to
Right.
basically step in day one. They were setting the PPS reimbursement based on the historical cost base. So we knew going in, we're going to step into an opportunity to be really profitable. And we were able to run 25% below the cost caps without technology. So my immediate thought, even though it was 1998 and what we call technology today and what we call technology in 1998 look really like different things, my immediate thought was, okay, how can I further automate and add even further efficiencies so that the 25% cushion I have today can actually even turn into a bigger opportunity for cost efficiency, which will create profitability in this post 2000 era. And that was really kind of the motivation. So I went out like any, wise consumer would do, and I looked at all the products on the market. And when I finished that search, I was pretty disheartened by what I found. Just nothing that was really designed to create operational efficiency, nothing that was based on a workflow engine, nothing that was really based on how to improve the clinical experience for patients and clinicians in the home. And so it was kind of like, oh, yes, there's nothing great out there. And about that time, I had a partner in those days, and he had purchased a company and developing some software for a completely different industry actually in the trucking industry. And he was like, hey, well, I got these software developers. Like, if you want to just build something, let's just build it. And so without very much forethought, once again, I was like, okay, I know what I want. So if you got a guy who can translate what I want into technology, let's do it. And so we kind of started that process and then identified a really key important technologist, Guy Consus, to come onto our team right from the beginning. And Guy could take my yellow pad and, turn it into tech. And he could take my thoughts and ideas. A few years ago when I was cleaning out my office, I found some of those first specifications literally drawn out on a yellow pad with flow charts. And, Guy could work his way through that. And so we just kind of started building this workflow engine, because I really thought the biggest problem in home care was sticky notes. That's how everything got managed. It was like, oh, put a sticky note on your monitor that says, oh, we need to reschedule Miss Jones. Put a sticky note that says, follow up with Susie about this change of order, or about, and sticky notes were the were the way you managed a home health agency back in the early 2000s. And I thought there's got to be a better way to create accountability within an organization. And so Homecare Homebase was sort of born just out of that. The market was missing something, and I thought I had a vision for what it really needed. Originally, I was planning on just having that vision be for myself. I was planning on just building an in-house solution. But as is always the case with tech, it's always takes longer and costs more than you imagined that it would. So about 2 years into that endeavor, decided, hey, this is probably not going to work as a single source solution. I need to spin it out. So we started the development in 99, and in the fall of 2001, spun it out into a separate entity, which was ultimately the birth of Homecare Homebase. And then basically threw away everything we had done for the prior 2 years and started over with a totally fresh code base, kind of built on the and the prototypes that we had done for our own agency. But we knew if we were going to make it commercial, we were going to have to build it a little bit differently in order to make it commercially viable. So we kind of started over with a fresh new code base in 2001, and then finally turned that company around really in 2007. And there was a real inflection point in 2006 that happened with Homecare Homebase, because people just think about Homecare Homebase as being this wildly successful solution that is now the market leader. But there were a lot of lean years. You came in kind of toward the tail end of those lean years, but there was a lot of lean years between 2001 and 2006. And in 2006, sort of hit this inflection point where my partner said, hey, I just can't keep throwing good money after bad. I got to stop. And I sort of felt still at that time that there was, lots of opportunity, but that we just needed more time. And so I remember once again going home to Mark and saying, hey, and he was having the same conversations, like, when do we get throwing good money after bad? And I said, hey, I don't know for sure that we're going to turn this corner. I know if we stop today, and I think at that point we were about $12 million in, I know for sure if we stop now, we will have lost $12 million. I think if we can put a few more million in it, we might be able to turn the corner. But to do that, we're going to have to buy out, our partner who couldn't keep funding the business. And so it was really one of those chips all in moments, because the other thing that we decided is that we needed to have much better sales if we were going to do that, our sales process. And so Mark's an institutional equity stockbroker, been in the sales business his whole career, and things are sort of changing in his career. And I said, why don't you just come join me? And why don't you run sales with Homecare Homebase? And not only will we put more money behind this thing, which resulted in us having to remortgage our house and then do a lot of things to create that capacity, but on top of that, why don't you quit your job and come over here and help me run this thing? And so March of 2006, we literally had an all-in moment for our family where any wise person would have said, don't do that. Any wise person would have said, definitely don't put all your chips in. Definitely don't quit your job so that you're both in this same basket. Definitely, don't remortgage your house and go long on that. But something
I remember that day.
Something within me just said, no, I think we have to. I think we have to try it.
I
And
remember real well, April. You came to me and said, "Tom, we're going to hire a new salesperson. He's not really qualified. He's a smart guy. He knows a lot, but he's never sold home health and hospice software. And I'd like for you to interview him at lunch. And you and Guy are going to have an interview with him." And I'm like, "Okay, can we get his resume?" And she's like, "Well, he really doesn't have a resume. I know him really well." I'm like, "Well, who is it?" He's like, "It's Mark." And I'm like, "Sure, April. I'm going to tell you, no, that's a bad idea. Come on." Of course, he's got the job. But we went and interviewed him. Guy and I took him over to there was a sandwich shop right down the street. And we spent an hour with him, and we knew him, but we actually talked, can we work with this guy? And it was fun. It was one of our greatest moves, I think. Mark, he was a hustler. He got the sales guys moving. He hired the right people, and yeah, I remember that. It was either we're going to shut this thing down or we're going to go all in. And thank you for going all in. I think it's paid for itself a lot. But it's an amazing story, and I think about his technology changed in that time. I mean, we were on the iPac. David Curtis and I did the first podcast, and we were talking about the iPac, and he bought the software in 2005, right as I was joining the company, and he's one of the first guys I met in this business, and now how it's evolved into, I always like to tell the story about how do we choose Android. That was Hamang Patel that came to us and said, we were on the Windows Mobile, Windows Phone 6 was what it was called. And he's like, "Hey, we're going to go to this from Windows Mobile to Windows Phone 7. It's going to be really great. And you can hook it up to your Xbox." And we're like, "We don't need all that." And we were in another inflection point in the business where it's like the devices that we were using were going away and nobody was going to make that technology anymore. And so we had to go figure something out. And I remember Guy and I going to Apple and tried to get Apple to do something. And back then it was only the iPhone and they were only on AT&T.
Mhm.
Most of our customers were on Verizon or Sprint or T-Mobile. And so we had like this panic moment, like we had to figure something out, and we solved it with Android. And then we started buying Huawei devices, and we find out Huawei's a company that nobody wants to do business with. And luckily, Samsung finally came up with the right tablet that actually, I think, makes it a way better experience in the industry. But there was some real inflection points there, like, "Uh-oh, what do we do now?" kind of thing.
I remember going on the black market trying to find devices that were no longer
Oh, yeah.
manufactured, that were refurbished, and just thinking
Oh, yeah.
the whole thing is about to collapse around our ears here if we can't find devices that our technology will run on while we're rewriting it to the Android platform. That year was like the customers who signed, and I can't put my finger on the year 2009. I think it was the customers who signed in 2009, right as we were making that transition into Android. I don't think they knew how risky their decision was. we were, it was a wing and a prayer whether or not we were going to be able to find hardware to actually run our software on.
That's right. I was on eBay. Buying Windows Mobile devices because that's all we could find. And you're like, "Hey, here's $50,000. Go find as many devices you can, stock them up. We need them." And I'm like, literally on eBay buying people's used devices just so we could have something to run. And yeah, I mean, those are fun days, right? I love thinking back to the stories that we had, but it was wild. Yeah, that's great. April, tell me about one of those patients. I know you and you and I've talked about a bunch of them. There used to be a guy that called you every week, and I can't remember his name, but I tell a story. But is there another patient or that patient out there that really just kind of that got you, that really makes you think about why you do this every day?
Yeah, he's still one of my favorites for sure. His name was Owen Perry, and I'll break HIPAA because he's been dead for a long time now. But he was a country music star in the 1940s. Had hit records in the 1940s on country radio. Played with Chet Atkins and all the big country stars of the day. Was on the what was it called, the Hayride or whatever, with Elvis. And I mean, he was
That's
like
awesome.
like Jerry Lee Lewis. He was like the real deal. But so one day I'm out. One of the things that I love to do, because culture is really the thing I love about building businesses, is building culture. And one of the ways that I think culture really becomes sustaining is that people have to feel like they work for people. They don't want to feel like they work for a company or an organization. They need to feel like they work for people, and can't feel like they work for April if they don't know April. And so I spend a lot of my time visiting our offices and talking to our people and making sure they really know what our mission is and what our passion is and what our heart for it is and how we're going to approach it. And so I'm out in Palestine, Texas, having one of these meetings, and people would obviously know a week or two in advance, "Hey, we're coming," and the whole care team in the field as well as in the office would come in. Well, this particular day, they said, "Hey, we've got this husband of one of our patients, and he read about you or heard about you, and he really wants to come see you. Is it okay if we invite him to come at the end of the roadshow?" And I said, "Sure, invite him over." So sure enough, we do the roadshow. We have a great meeting with our team, and then I go out meet Mr. Perry. And what a just a delightful man he was. He by that time in life he was about 5 foot. You know how you shrink as you get older. He was just a little guy, but just had an infectious smile and the greatest personality. And he was in his 80s already at that point in time. And his wife had been on our services, and he just was so complimentary of our staff. And so we just sort of developed over that course of about a 45-minute introduction, a little bit of a friendship. And he said, "Hey, can I call you and stay in touch?" And I said, "Of course." So we ended up, talking on a regular basis and became friends. And over time, he ultimately ended up being one of our patients. But in the end, he really ended up being like a second grandparent to our children. We would go see him at the holidays. We were there with him just about a week before he passed away. He was in a nursing home at that point, but just had a great life story. And, I think one of my guiding principles, I have some guiding principles that I try to live by and that I try to make sure our company lives by. But one of them is everyone is someone's most important person. And when I think about Owen Perry, he's one of those examples. It's just, it would have been easy to be like, this is just a little guy who doesn't, have that much going on, but he had this amazing life story. And his children didn't live near him, and he didn't really have anybody in his world right then who could really kind of step up for him. And we got to be those people. We got to be them with our clinicians. I got to be them as his friend. But, for every one of our patients, that's what we really want to get our team members thinking about is, hey, everyone is someone's most important person. If you'll just take a moment, you're going to find out something about this person's life story. It's just going to be amazing. Maybe it's that they had a #1 hit record on the Billboard chart. Maybe it's that they were a fireman. Maybe it's that they spent 30 years teaching first graders. What is it? But every person has got something in their life that just is a story that we need to know. And I think when in home care in particular, our relationship is so different than it is with a hospital nurse who's going to see a patient for a day or two, and then their shift is going to end. And when they come back, that patient's moved on to a different place or a different floor. They don't sometimes know if they've lived or died. They just know they're not there anymore, and they don't really have time to keep up with them all. But in home care, we develop relationships with our patients. Our tenure of service with those patients extends over time and over months. And we get to hear their stories and know their stories, and we get drawn into their lives and they into ours in a way that's just, really special. And to me, that's, when I'm obviously not a clinician, but when I talk to clinicians who've never done home care and who may have some predisposed opinion about whether or not home care is the place they want to be or not, I always tell them stories like the story of Owen Perry, or like stories of so many of our patients, where you just say, you're going to get to know your patient. Not only are you going to transform their life through the quality of the care that you deliver them, but you're going to know their story and they're going to know yours. And, there's just so many instances where people have been able to say, this patient ended up, being a friend, and they ended up asking about my kids and knowing my story. And it's that relationship that's so unique in the home-based care delivery, whether it's home health or hospice, that just really makes such an impact for our clinicians. And I think when you find somebody who connects with that, then they'll never not work in home care again. They're never going back to the hospital, because that's the part that makes them feel great about what they do. I love thinking about Owen Perry and that everyone is someone's most important person.
Yeah, and I totally appreciate that. I have the same story. And, Encompass took care of Nana when Nana was sick. And that's why we started Muse, is the chaplain recognized that Nana was on her last days. And he told her to call the family. And so she called me. I was on the golf course. I always tell the story on hole number 6 at North Oaks. On hole number 6, I got a text from my dad, said, your grandma's about to call you, answer the phone. And so I talked to her for 45 minutes. And luckily he recognized that it was her last days, and she had a big tumor on her head and didn't want to see us because she was embarrassed by that, but she wanted to say goodbye. And so I spent 45 minutes and said goodbye to Nana, and it really touched my life. And so it's thanks for sharing the Owen story. And I remember us talking about it for many years. Like, this guy calls you every week, and and it's, most people would be annoyed by that, but you were always welcoming and looking forward to that phone call. So another one that I always like to talk about, because I deal with this every day as well, is you work with your spouse. And I think it's one of the hardest things in the world to do. My wife works with me every day. And so talk about that. Is there lessons learned or things you should do or not do? I mean, and I know Thanksgiving at your house is all about home care and hospice because it is at mine too. My stepson's works for us at Maxwell Tech, and then his wife is a social worker at St. Croix Hospice. So you can imagine what we talk about at Thanksgiving. So how do you overcome that? And any lessons learned working with Mark over the years?
Yeah, exactly. So we managed to work together from 2006 to 2015, and are now working on our 34th year of marriage. So
It's amazing.
we survived that era. It was hard though. It was hard in a lot of ways. It's also it's hard to work with your spouse because it's sometimes the lines get blurry. You'll say things to your spouse and to someone that you have that kind of relationship with you would never say to one of your coworkers. You'll make offhanded comments that you would never make. Your level of professionalism is not the same, and then you find yourself sort of treating that person in a way you would not treat anyone else that was actually on your executive team. And so I think you have to just really be guarded about that. Like, okay, wait a minute, I have to still remember that this is a different kind of relationship. And then you have to be careful when you go home because then you still want to be that person's boss. You're like, and Mark would always be like, hey, it's 5:00. We're done with that. You're not my boss. But I think it is definitely a challenge and a unique experience, but it's particularly unique to be, the woman who's the boss of your husband in the daytime. And so that was a challenge. And I attribute the success of that to a couple different things, but mostly to Mark because, a lot of guys, wouldn't take well to that. And, Mark has just never been a guy he never had an ego about anything. He didn't have an ego about roles, traditional roles or, he would do whatever needed to be done. When our kids were little, we shared that responsibility. It wasn't like, hey, that's the mom's job and this is dad's job. He would go work the lunch line if that's what needed to happen. He would volunteer when it was nothing but moms that were volunteering to do things if that's what needed to happen to get the kids through the situation that was upon us at the time. But I think his humility was a huge part of why that was successful. And then I think, in the end of the day, thankfully, it was successful in that the production that occurred during those years, actually was positive for the business. And I think it would have been even harder had it been, unsuccessful in the professional realms. Like if we hadn't achieved sales goals, if we hadn't been able to do what we needed to do, it would have been, an even harder time. But it is a struggle. And I would definitely caution couples that if you're going down that path, you kind of have to lay some ground rules and you kind of have to be like, okay, here's how we're going to work together. Here's how we're not going to work together. Here's what we're going to not do. Here's what we are going to do. And I think, if you one, set those ground rules in advance, and then two, be pretty consistent about evaluating. Are you doing that? Because in the end of the day, nothing's more important than keeping your family together. And, there's not a situation where risking that for whatever business output you're seeking is a good outcome. So, just being really intentional about those rules and then consistently reviewing, hey, how is this working on both the professional front and the personal front? And it might be successful on one front, failing on the other, and that's probably not good on either side. It doesn't matter. And you got to have enough transparency with one another to kind of say, hey, this is not working.
Yeah, I use it to my advantage a lot. When you're on your road show, I'm like, hey, Mark, I got to get an answer from April. She's on the road show. When you see her tonight, ask her this question. And he's like, well, I'm not supposed to do that after 5:00, but I'll get you this answer tomorrow. So, but it's tough. Jennifer and I have gone through it. We've actually gone to couples communication counseling in Sedona. We did a retreat just to figure it out. And we were co-CEOs for a while, and that was the dumbest thing I ever did. Like, because everybody would go to mom or dad, or, they'd go to me or her, and I'd say, yeah, that's approved. And she'd be like, hell no, we're not approving that. What are you doing, you dummy? And then I'm mad. And then, we take it home, and for 3 weeks, you're not speaking to each other. And it's awkward. So you guys, and I worked with you both during that time, and you guys figured out how to handle it pretty well. And and you were running 2 large companies at the time. So the demands at home were really tough. I mean, I remember when Allie was born, and we grew up with her. Now look at her. I mean, she's turned out to be, a movie star, essentially, or newscast star.
I think that's important too, is really, it's one thing about how it's affecting your relationship. How does it affect your kids' relationship that you work together? Because it is hard to turn the switch. Even if you turn off the switch of kind of boss, it's still hard to turn off the switch of like, we're still talking about work all the time. You know, a lot of times the kids just roll their eyes and be like, stop it. Like, okay, okay. You know, they would have to set us straight and be like, quit talking about work at the dinner table, you know.
That's right. What about me? Well, cool. Let's jump back to technology. Today, everything's changing. AI is out here. We're all building different technologies with AI. Where do you see this going? And what scares you? And what excites you about, all the different AI tools that are coming out for home care and hospice?
Yeah, I think the one that excites me the most is the one that makes the clinician's job easier. I think, the opportunity to have ambient listening tools and things that allow you to be even more connected. I think, the handheld solution is a lot better than the laptop solution as it relates to the patient experience. But I
For
think
sure.
the ability to be able to have, no tech between you and the patient really, and to be able to really keep your eyes constantly focused on the patient and be able to have that patient really sense your connection to them as opposed to hang on 1 second, I got to document it. And I know that's the reality we live in today, but the potential that wouldn't have to be our future reality, almost a back to the future from a standpoint of, taking the tech out of the home, but yet having it there in a way that is completely non-intrusive to the relationship with the patient. I think that to me, that's the most exciting thing on the horizon because I can see how that will drive improved quality, improve patient experience, improve patient satisfaction, and hugely improved employee satisfaction. So that's the one that probably intrigues me the most. If it can really work the way we all hope it will, then I think that's going to be pretty amazing. And so I'm super encouraged by what that could do for the industry. And then I think our industry has just become burdened with so many technicalities, like so many things that you have to comply with in order to avoid a subsequent audit or a subsequent issue or a subsequent denial. And so trying to just sort of figure out how do we really manage all those technicalities in the most efficient way so that the humans are really focused on doing only those things that the human can do, where human discernment is necessary and tasks and functions that can be automated, fully are. And so, some of that's robotic processing, some of it's true AI, but I think that's exciting. And then, I still long for the day. I remember joking back in the early 2000s, like one day we're just going to take the iPad and we're going to wave it over the patient. It's going to do everything for you. You remember those conversations?
Yeah, for sure.
We're not going to have to do anything. And, we're not quite there, but we're getting closer to a
We are.
place where it's the tech is going to be able to kind of pick up on all of that for itself. But I think also developing care plans that are really effective. One of my other guiding principles is add value in every encounter. And that not only applies to every visit, it applies to every administrative meeting we have, every every Zoom call we have. Like I think in this world we get into a tendency of doing things habitually. We do things because we always have a Monday morning meeting, or we do things because we always see CHF patients this way, or whatever. And so, really stepping back and saying, what value? What is the value we are adding from this encounter, and how do we make sure that the time we're asking our teams to invest is really time well spent? And so, I think for our patients, how do we really seamlessly bring in at the right moment the technology that can say, this is what this patient needs to have the highest probability of success? And instead of it being a suggestion or something that comes along after you've completed all of this, that, and the other, and it finally shows up, and by then you've kind of already made your mind up to do something else, how do we get that intelligence early in the process so that from the very beginning, the technology is guiding the care plan instead of it coming in after the start of care and after the OASIS review and after the scrubber and blah, 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 blah. And then finally, here comes a recommendation. By then, the ship sort of sailed, and sometimes it's already sailed in a little bit different direction or a little bit different commitment to patients. So I think getting that evolution to move further along so that it can be right time, right place, and it can change behaviors from the very first moment instead of try to revert behaviors that have already started in a wrong direction back in a right direction.
That's right. We keep talking about, like, with all these ambient listening tools, like, how do I get a nurse to want to do a start of care versus have to do them?
Oh,
Today, they
totally.
have to do them because April says you have to do them, and I'm going to pay you more to do a start of care. It's the one visit that everybody, surveys, scrutinizes. It's the one visit that you get paid on. It's the one visit that all your friends are reviewing. Everybody that works with you is reviewing, and they're grading your paper. And it's a long time consuming visit. I always say, if you had told doctor he has to fill out an OASIS questionnaire on every single patient he sees, they wouldn't see any patients anymore. And so we have to make that easier. And, the starter cares are now like 2.5, 3 hours. Some people are doing 4-hour starter cares. Like, how do I make that an easy visit and make you want to go do that? And help you build that care plan. It's patient-centered care plan. Like, what does that patient really want, and how do we get there? And then how do we do the right amount of care for that patient? And I love that every encounter should be impactful, because I think it's super important. And there's tools out there that are doing this. I mean, the banking system's figured out how to be interoperable. Why can't we? And imagine if you had to go fill out all your account number and your routing number and all that stuff on every single transaction you did in the bank. I mean, now you just go to the grocery store and swipe your phone. You don't even need a credit card anymore. You just swipe your phone and pay. But we have to get better and easier in that. And I think home cares and hospice, it's just getting harder and harder and harder to do this business. And we're getting scrutinized more and more and more. And so I think these tools are there. I want them to be embedded into whatever EMR you're using, whether it's Homecare Homebase or Major Care, whoever. They have to be embedded into those and make life easier for the clinicians. And then I think we'll get more clinicians. I mean, the one thing I hear mostly from clinicians that I interview or talk to is home care just got too hard, or home health is just way too hard. It's too much paperwork, too much documentation. I'm already driving around all over the town. I'm already, by myself doing med reviews that I normally didn't do in the hospital because I had a pharmacist doing it or a doctor doing it. I'm doing wound care. I'm doing spiritual care. I'm doing emotional care. I'm dealing with families. I'm dealing with maybe some yucky environments. And then you want me to do all this paperwork too at night? Like, it's terrible. And so we'll get there. I'm really excited about the future of it. And, I want to do it compassionately, but also very quickly. I want it done fast so we can give back these nurses back some time. And they need to see more patients. We need to be able to see more patients. But if we, burden them with documentation all the time, they're going to see less patients.
Yeah, and I think that's going to be, one of the tells of it, because I'm pretty convinced we can make documentation more efficient. The tools are evolving to a place where very quickly we're going to see improved efficiency in documentation. What's going to have to happen though is we've got to get more throughput for that, because if all I do is make the clinicians work easier, but I don't get more production in exchange for making it easier, then I can't afford to pay for the technology. And so it's really about, okay, how do I make sure I'm pitching this in such a way that the clinician is really on board with it, to say, I've expected 30 points of productivity from you in the past. And, now because you have this tool, I'm going to be able to go up to 32, or I'm going to be able to lower the point value on starter care from 2.5 to 2, because it no longer takes you 2.5 hours. It now only takes you 2 hours. And so we're going to bring that point value down. So one way or another, I've got to get that exchange. And I've got to get that consistent productivity, back out of that clinician. And so, I think there's an objective value that's going to come to the clinician. And I've just got to make sure there's some sharing in that value that comes back the way of the company, so that we can afford to provide you with those tools, to make it really easier. And I know that's been hard, because I can go all the way back to, 33 years in the home care space. And I can really see where productivity, even though things have changed dramatically from 1992 to current in what it takes to do a visit and document a visit, the actual productivity statistics just aren't that different. We were doing, 5 visits a day in 1992, and we're still kind of doing 5+ visits to, 5 to 5.5 visits today. And so it's really, we haven't made that transformational shift. And obviously since 1992, there's been oodles of additional documentation that are required. So, we've sort of achieved it by saying, well, I can still do 5 to 5.5 visits a day, even though I have this bigger documentation burden than I had in 1992. That's the efficiency that we've created, is that added documentation hasn't taken away from what we can accomplish, but we've got to get to a place in an environment where rate pressures are constant, where I can actually get more out of my clinicians. But I've got to do it in such a way where I'm not asking more of them. I'm still asking for the same time commitment. I'm just going to get more transactions during that committed time. I also think we've got to look at at when transactions need to be face to face versus when transactions can be done otherwise, whether it's telephonically, whether it's a virtual visit. And as our aging population becomes more and more tech savvy, I think we're going to find more and more times where we need to be supplementing face-to-face visits with virtual visits or even telephone interactions in some instances can accomplish a lot of the same thing. And I think if our rates keep getting pressured the way they are, we've got to also really push into how do I get equivalent value in a less costly way.
Yeah, it's amazing the physicians all get to do virtual visits. I mean, we all do that now, right? I haven't been to the doctor in forever. He does. If I need him, I call him. We jump on Zoom or whatever, and he looks to my mouth and asks me to take my blood pressure and my temperature and asks me what's going on, and then we talk about it, and then he treats it. And I don't go to the doctor very often, but the same thing happens to all of our loved ones that are out there. Next topic that I'm really looking forward to is Medicare Advantage. Back when we started this thing, it was all Medicare. We were 98% Medicare, 2% non-Medicare, and then we went into the hospice business. And what's making Medicare Advantage, one, grow so much, and then two, how are we going to tackle this? The reimbursement for these Advantage plans is way less. The utilization is way less. There's a great article that came out on JAMA that Cole will post in the show notes here, that if you're a Medicare Advantage participant or member, the chances of you getting a high quality home health agency are really lower. And I think it's super interesting that, just because you chose, one of the big Medicare Advantage payers to care for you in your insurance needs, you're going to get a less quality home health provider. So how do we overcome that? And your thoughts on that? I know you deal with it every day.
I think there's a couple of ways. One, we have to keep working on our value proposition. And at the end of the day, you don't get paid much when people don't value what you do. And I think we as an industry continue to struggle to prove our value to the insurance companies. And part of that is because it's a difficult thing to prove because we're often proving a negative. We're trying to say, look what didn't happen because I was there. This patient didn't go to the hospital because we were there. They're like, well, really? Or were they not going to go to the hospital anyway? So it's hard to prove what didn't happen because we were there. And so I think it's a difficult proof to begin with. So I think we've just got to keep working on more and more ways that we can support our value proposition. I think we've got to work on more and more ways that we can be more efficient so that we can be a trusted partner. So that instead of them being worried about, well, I'm gonna pay you this per visit rate, then you're just gonna do as many visits as you can do, because you're gonna, more visits, more revenue for you. We've got to find a way to be a more trusted partner so that they can actually pay us a living wage for the transactions we do and be confident that we're going to add value in every encounter and not do more visits than are needed than we need to be done. So we've got to work through those things. And then I honestly think it's going to take, to some extent, some government intervention, because I think that path to sort of proving value directly with them, just getting enough attention from them, given what home health is as a percentage of their medical loss ratio spend and what everything else is, it's just hard for them to care that much. And so I think that's getting to be harder. So I think it's going to take some government intervention to say, well, wait a minute, you signed up to be this Medicare Advantage plan, committing that you were going to provide the bundle of services that are provided by Medicare and maybe some additional ones, but at a minimum, you were going to provide the same bundle Medicare paid. And I think there's some debate to say, are they really doing that? If in fact they're paying a rate that's a 40% discount to what Medicare's rate is, are they really providing the same bundle? Because the reason no one can find a quality home care provider in that universe is nobody gets paid a quality rate. And so it's hard to say, is it really provided if you're paying it out at such a discount to the Medicare standard? Are you really even providing home care services to those beneficiaries? So I think we're probably going to need some help from CMS and others to be able to say, wait a minute, these providers aren't living up to their end of the contract. And if they end up discounting a service at such a degree that it's so far below market, then yeah, their recipients aren't going to have any home care providers that are willing to see them. And if they are willing to see them, it's going to be like their last priority and that's why they're getting, late start of cares. And that's why, and, at some point, hopefully they'll step back long enough to realize, the payers themselves will step back long enough to realize, they're kind of their own worst enemy with this choice, because they really are creating incremental spend, they're creating incremental dissatisfaction, they're creating incremental risk for patients. But at some point, they're going to have to care about some of those qualitative components just as much as they care about the quantitative components. Because I think that's the other thing that's really missed. Like, sure, maybe that patient would go home and maybe they wouldn't have gone back to the hospital after all. But what really happened in that transition home? And was that the kind of experience that you would want to have if it was your mother that was going home? Because, oh, remember, everyone is someone's most important person.
That's right.
So it kind of comes back around to like, how do we get those insurance companies to say qualitatively, there is value that's going to result in patient retention, customer retention in their minds. They're going to keep that customer part of their plan instead of that customer fault. And then I also think there's a little bit of perverse incentive that says to the insurance company. We used to make jokes that the Medicare Advantage plans would always put their signups on the second floor of a building with no elevator. Because the only people they wanted to sign up were the people who were healthy enough to make it to the second floor with no elevator. But I think there is a little bit of a perverse incentive still that says they want to cull out the Medicare Advantage or Medicare population, and they want to cull out this. They want to be paid based on the average, but then they want to create a disaveraged population to be their consumers. They want to pick a younger, healthier, more independent consumer, because if they're going to get paid the average rate, but they're going to have a better than average population, then they're going to create lower medical loss ratios and more profitability. And so there's this kind of perverse incentive that says, well, gosh, if a patient's getting to the place where they really have high needs, and that's what happens with our Medicare patients, who average age 78, many are in their plus 85 range. Do these Medicare Advantage patients really even want to keep that patient? Or is it kind of like, hey, if my service level is not that great, the patient will leave and go back to traditional Medicare? And we'll end up with a population where Medicare Advantage is the younger, healthier patient, and traditional Medicare is the older, sicker patient. And yet, if you pay an average rate to Medicare Advantage plans, and that reality exists, they're going to make more money, and the government's going to have a higher spend than they anticipated. And so I think there's some place where we're going to have to say there is this perverse incentive that the government's going to have to look at. How do I address that? And how do I really acuity base rate a population of patients? And we all know a couple of years ago, every insurance company was going crazy with these scoring visits that were, driving scores up. There's been, oodles of articles about that whole process. And so how do we really independently do that? How do we independently assess the population, and how do we segment it in such a way that the high needs end of the population doesn't all end up in traditional Medicare where the government's carrying the heaviest expense?
Yeah, or we're going to run out of money. I mean, it's true. It's going to be gone. All right, we got one more question, and then we got to wrap up. So, and I love this question. I can't wait to hear how you explain this answer. But if you can leave a legacy, or if you want to be your legacy in home health and hospice, or April Anthony as a human, what do you want that legacy to be? And what do you want people to remember you as? Not that you're going to be going away anytime soon, but the reason why I get up every morning, and lots of people ask me, why is April still doing what she does? She's been very successful in life, and she's made it an amazing living for her family. And why does she keep going? And I always tell them, she's just like me. She's a workaholic, and there's too much of a mission left. And what the heck would we do? I mean, you're an amazing golfer, but playing golf every day is not that much fun either. So why do you keep doing what you do, and what's your legacy?
Well, I mean, I think I keep doing it because I feel like I've been gifted. I feel called to the work, and I feel like I've been uniquely gifted by God to have a skill set and a set of abilities that lets me be really successful at it. And so in the year that I took off, 2021 to 2022 timeframe, I think I played 154 rounds of golf. And I'm a pretty good golfer, but I'm not a gifted golfer. And I was able to get my handicap below 5. And then all of a sudden it started creeping back up into the 6s and 7s. And I'm like, this is not enough. This is not enough. And so, for me, I think it's about really looking at all that has happened in my life, all the success that's been given to me. And then am I being a good steward of that? And it just felt like, playing golf 154 times a year wasn't that. It was fun, and it was a good break, and I enjoyed it, but it just felt like that there was still a passion within me to do it. There was still a God gifted set of talents within me to do it. And then there was the ability to really say, you know, how do how do you use those talents, and then what does God want me to do with those talents? Not only what does He want me to do with the talents, but what does He want me to do with the rewards that those talents create? So I love creating a place where people say, I'm a better whatever because I work at Vital Care, and I'm a better nurse, I'm a better therapist, I'm a better accountant, I'm a better medical records assistant. I'm better because this organization kind of brings that out in me. And what I think is, if you can make people better in their work, if you can make somebody say, I'm the best nurse I've ever been anywhere in my career here, I believe that that transitions into the rest of their life, and they go home and they think, you know what? I've been great all day. Like all day, I've just been crushing it. I've been doing great work. I've been making a great impact. I've been noticed, appreciated for it. And I want to come home and I want to be a better mom, a better wife, a better spouse, a better neighbor, a better member of my faith community, a better member of my local community. And I think when you experience greatness at work, it makes you want to have that same kind of greatness in every other aspect of your life. And so I hope my legacy is that people will say, when I worked for April, I was the best whatever. And that translated into me being a better wife, a better mother, a better spouse, a better Christian, a better, member of my community. And if you can transform not just people's work experience, but you can really transform who they are in all aspects of their life. That that's something I'm striving for, and that's something that I think we've done sometimes. I don't think we've done it with every time with everyone, but I think we've had a lot of success at that, and I think that's what makes me wake up every morning saying, how do I make every member of my team the best they've ever been? And then how do I see what God might do with that motivation that's created and that experience of being the best at work? What might He do with that in other aspects of their life?
That's amazing, April.
That
Yeah.
makes coming to work every day fun. Even more fun than making a play.
Yeah, I did the whole 71 days of golf every day. It was terrible. The only decision you have to make is it a blue shirt or a red shirt, or is it a 7-iron or an 8-iron? And it's terrible. Like I love playing golf. I play all the time, but I hated just doing that. And I think about you as if I was going to answer that question for you, just like you said, you made it fun. But I think about the number of people that you've touched and gave the opportunity in their lives and their careers, and the number of kids that have gone to college, or people that made their house payment or bought things, or you've made so many people in this, whether it was Encompass or Homecare Homebase or Vital Caring or even previous to that. The number of opportunities, and think about all the ACU students that came through our incubator at Homecare Homebase that are now super successful, and a bunch of them work for me now and work for other agencies. I always think about the story when Jim Griffin and I came to your office. We were mad because Accent Care had taken one of our employees, and Jim was ready to sue him over it, and you were like, no, guys, this is what we're doing. That person's going to go into Accent Care, and they're going to be the best evangelists for Homecare Homebase and what we've built. And, they're going to always support us. And so why would we be mad about that? Let it go. And it touched me that day. I was like, wow, we've given so many people opportunities, and it all started with you and what you've done. And so I'm really proud of that, and proud to be a part of it, and proud for you to be my personal mentor, and you've made my career successful. And I want to thank you and Mark for that. And so thanks for taking the risk and you giving us all the opportunity.
It's fun. It's fun to now see, with 33 years of time in the rearview mirror, like all the people who've really matured into amazing leaders in their career, and that we had the opportunity to sort of touch them early in their career, and kind of show them this passion. Because when I think about the home care industry now, you go back 5 years, 7 years, it was such a different place. It was all the biggest companies were led by people who were founders of their businesses, people who'd been in the business for a long time, who had this, real deep connection to the industry. And now the home care industry's changed a little bit, and there's been this moment of evolution, and you've just lost some of that sort of connectedness that came by all of these generational founders who had been in their businesses for 20 and 30 years. And now it's a new moment. and just this opportunity for this new batch of leaders to step in and say, what are you going to make your legacy? And how are you going to make sure this industry really continues to have the impact that it's had in years past? How are you going to be that next generation leader that's going to push the home care industry forward? And how are you going to rise up and be the kind of transformational leader that some of our past leaders that have stepped away now from the industry or moved into retirement or even not with us any longer? How do you become that next generation leader? And I hope some of those will look to the successes that some of us had in that process, and will lean into those and say, you know what, I want to be the best place to work. I mean, think about it. If everybody in home care said, my goal is to be the very best place to work, I don't think we'd have staffing problems in our industry. I don't think we'd have
Sure.
problems with not being able to accept all our referrals. I think people would be saying, I want out of the hospital. I want to come there because that is an amazing place to work. And so I want our industry to raise the bar. And I hope they'll learn lessons from the past, but also look to innovations for the future, but just not lose the heart behind our business, because it's the end of the day, you are being invited into someone's home to care for them. And if that doesn't tug at your heartstrings, then you shouldn't be in this business.
It's amazing. I'm sure your mom and dad are super proud of you, April. I know they always used to tell me they were, but I'm sure they're sitting up there smiling right now. So thank you for joining us today. It's always a pleasure to spend time with you, and we always learn from you. And I super excited that everybody gets to hear this podcast. So thank you for joining us today.
Great to visit with you and catch up. And thanks for all that you've done in the industry and all the things yet to come that are before us. It's going to be
We're just
fun.
getting started.
In spite of all the headwinds we experience in home care right now, I'm as enthusiastic and as hopeful as I've ever been that home care just has a bright, bright, bright future.
It's awesome. Thank you.